because we have the participants from all over the world. So welcome all of you. As the General Secretary of the Nephro Critical Care Society, I am really excited to welcome you all for the Nephro Critical Care webinar series 2. The first one we concluded last month, that was based on plasmapheresis in Nephro Critical Care. And this is the second one in the series. And we are also having 3 more in next 2 weeks. And then followed by, we have I can say this is the third one in the series, and that is the Nephro Critical Care review course that would be at Kottayam. And we are happy to have, as well as honored to have, experts across the world. And this is something we are expecting that would be embarking on the journey of enlightening the academic exploration and diving deep into the latest advancements of nephrocritical care research, clinical practices that would be shaping, I would say reshaping, the nephrocritical care future. Our meticulously curated sessions, we are conducting this for last 1 year, and definitely the distinguished panel of experts that we had, they have stimulated insightful discussions on critical care nephrology. So without further wasting the time, I would be also sharing the topic titles for our upcoming webinars in this month itself. 8th April, we will be having extracorporeal therapy in sepsis. 18th April, we would be having diuretics and beyond in nephrocritical care. On 23rd April, it would be volume management in critical care, and specifically nephrocritical care. So definitely the session would be having the core expert nephrologist and intensivist from all over the world, the panelists as well as the speakers. And then we'll be having on 27th and 28th, the third one in the series of nephrocritical care review course at Kottayam, Kerala, India. And that would be definitely the review course which everybody is waiting for. And we are having many of the new things for the first time. Almost 70% of the review course would be hands-on, and 30% would be only didactic lectures. And that's the reason why we have chosen that there would be some of the topics that should be discussed pre-conference as part of the webinar series, so that the candidates would be having the few concepts cleared before attending the review course. So the review course should not be of more theoretical. Now, the today topic agenda would be the topic which would be discussed by none other than Dr. Valentin Lobo. He needs no introduction, and he would be talking the newer targets of renal replacement therapy in critically ill acute kidney injury. And that would be exploring newer therapeutic frontiers. With me, I have Dr. Sananta Kumar Das, who is the Academic Secretary of Nephrocritical Care. So, hi Sanant. Sanant is from Australia and he is on call there. So maybe it would be a little bit difficult for him to join, but definitely he would be part of the discussion. And with me, hi Sanant.
Hi.
Good to
thank you for the introduction, and a very good evening to Dr. Lobo and Dr. Ashraf and Dr. Chakravarti. Carry on, Tapas. So
Thank you for joining, Sanant from Australia. And after the talk, we will be having a panel discussion where 3 of our eminent panelists, I would be now sharing the names in front of the attendees. Dr. Raj Shekhar Chakravarti, he is one of the doyen in nephrology across the world, clinical director, nephrology and renal transplant services from Jasoda Hospitals, Hyderabad, India. I know how the core academician he is, so we are happy to have him. Dr. Ashraf Mahmood El Hopi, I already told, I know him for last 9 years or so. He is a fantastic orator and also core academician. He is the consultant and head ICU at Dubai Hospital, professor of medicine, Dubai Medical College, chairman of the Infection Control Committee at Dubai Hospital, Dubai. Welcome, sir. And finally, Dr. Pradeep Prangapa. He is one of the most renowned intensivist online and offline as well. So he has his own YouTube channel, and where he has almost, I think, to the tune of 400 or 500 lectures which have been uploaded. And he is joining from Manipal Hospital, Bangalore, India. So, and with me also, I would should not be forgetting the ISSM chairman, Kottayam branch, as well as the organizing chairman of the third nephrocritical care review course, that is Dr. Jacob. So welcome, Jacob, to the second in the series of our the Lifeline webinar series. And finally, we would be having the quiz for the young trainees and the attendees who would be scoring the highest mark in this and who are joining as the attendee in our nephrocritical care review course at Kottayam, they would be directly going to the grand finale. So that is again one thing. And the other candidates who are joining online only, so they would be getting exciting prizes if the score would be the tune of the top 3. So with this, I am not going further. So I am just right now requesting our speaker as well as panelists, and the panelists please carry forward the session. Yeah.
Okay, I'm just trying to make it slideshow.
Yes.
Yeah. So thank you, Tapas. And I'm happy to be a part of this great initiative that you've started, and look forward to learning from all my co-panelists also over here. So Tapas gave me this topic and he said, think about what you would think would be new targets in renal replacement therapy. So the outline of my topic is going to be, why do we need newer targets? To go quickly ahead, I'd like to start by describing a case. So this is a case of a 67-year-old woman who was admitted with high fever, jaundice, and abdominal pain, went on to develop an anuric acute kidney injury with hyperkalemia, a blood urea of nearly 400, and she was initiated on a long dialysis lasting 11 and a half hours with a low blood flow, but which produced almost a 70% reduction in urea, which corresponded to a KT by V of 1.4. She went on to diuresis, recovered renal function, and was discharged and did perfectly well. Now, this dialysis was performed by this man, William Kolff, seen at the bottom of the screen, on the 11th of September 1945, with the dialysis apparatus that is seen here, his rotating drum. Since Kolff's time, we have come a long way. Kolff was a genius who, for 15 dialysis he performed, he used machines which he made from a Model T Ford's water tank, a washing machine, sausage skins as dialyzers, and then went on eventually to the rotating drum. At the same time that Kolff was doing this successfully, Nils Alvol in Sweden performed dialysis and ultrafiltration using the first cellulosic dialyzer, and Alvol's machine went on to become what is today Gambro. Between 1954 and 1962, the Brigham Women's Hospital modified Kolff. Kolff by then had moved to the United States and was over there and along working at Brigham Hospital, where his original drum was modified to the Brigham Kolff kidney, and it decreased the mortality of acute kidney injury from 100% to 50% during the Korean War, which was going on during the 1950s. Then in the 1970s, Peter Kramer accidentally cannulated the femoral artery and performed the first continuous arteriovenous hemodialysis at a speed of 100 ml per minute. Then came the development of continuous renal replacement therapies, adaptive technology, and second generation machines. And today we have third generation machines with high technical accuracy and safety, which provide multi-organ support. I'll concentrate for a minute, and maybe we don't look at comparisons here, but these are the high quality studies which have been done in the last 2 decades. And when we look at what it has achieved, we have mortalities which vary at 90 days or 60 days between about 44% to about 58%. So it appears that when Kolff brought it down from about 100% to 50% in the 1950s, over the next 70 years, we seem to be at roughly the same state in saving our AKI patients' lives. Now, there is a time when people say, oh, in the evolution of AKI has changed and we shouldn't be looking at mortality anymore. And I'll take a few seconds to say why I differ with that opinion, because it's imagine that any of us would go to a patient's relative and say, now look here, we are going to start this new treatment for your patient, which is going to double the costs of care, or the daily cost of care. Your patient isn't going to increase his chances of survival, but he's going to die with a better blood pressure, a better oxygen level, and a lower blood urea level. I don't think any of us is going to say that to a patient, but that's essentially what we're saying if we aren't looking at efforts to save lives of our patients. So, what have we tried in the last few years? We've tried early versus late dialysis, renal replacement therapy, intermittent versus continuous, high dose versus low dose, diffusion versus convection. I'm not going to talk about the adsorbent therapies for sepsis because next week Dr. Ramesh Venkatraman is going to cover that topic in great detail. So back to where we are, and we have tried to, only the Vicenza study in 2000 was a positive study, which said the 35 ml per kg per hour of CRRT was better than 20 ml per kg per hour. But after that, the ATN and the renal studies, which were multi-center studies, were unable to duplicate those results. Then we had high volume, 70 ml versus 30 ml, and the study was abandoned, failing to show a difference. Then we had a comparison of CRRT with SLED, no difference in the outcomes. And then we had all these great trials on early versus late. And once again, no real difference in mortality. So let's look at what we do dialysis for. We would dialyze our patients of AKI if they have pulmonary edema, if they have severe acidosis and hyperkalemia. And we know today that AKI produces distant organ damage. And so we look at the end organ damage in the form of encephalopathies, pericarditis, etc., and we target we target these end organ damage as well with our renal replacement therapy. But what does KDIGO tell us? What they tell us is that we recommend delivering a KT by V of 3.9 per week. So what's that mean? That gets a 1A grading. And what that means is that we need to, in each session of renal replacement therapy, reduce the blood urea by around 70%. And it also says that you target, if you're doing CRRT, an effluent volume of 20 to 25 ml per kg per hour. And that gets a grade 1A recommendation, and everything else is not graded. So we are looking at patients who have pulmonary edema, who have metabolic acidosis and widespread organ damage. And what we're trying to do is to reduce the blood urea level according to the recommendations. Now, these are the Indian recommendations. And the only difference that it does add that more frequent or longer sessions may be determined by the need for ultrafiltration. So we're going to tackle fluid overload, hyperkalemia, and metabolic acidosis rather than only an enhanced urea clearance. So there was a realization in 2020 when the Indian Society of Nephrology was writing its guidelines that there was a need to look beyond blood urea reduction and target ultrafiltration, hyperkalemia, and acidosis and do it in a better manner. So this is what we target at present. We target a small solute urea, and we don't look perhaps enough at fluid balance. We need to correct electrolyte and acid base disturbances if we are to improve our outcomes. But is there any evidence to say that by doing these things, we will do better? This is well established. It was first in pediatric populations and then in adult populations. If fluid overload of more than 10 to 20% from RRT, from ICU admission occurs, there is a significant increase in mortality in patients. However, in 2017, when Sean Bagshaw wrote this article, he found that there wasn't enough evidence to say that removing this excessive fluid would improve patient outcomes. So where are we today? This is a post-hoc analysis of the PICARD study, which was a study done across 6 intensive care units in the United States. There were more than 600 patients involved, and about 400 of them required renal replacement therapy. And fluid intake and output balances were available in 350 of them. Now, what the study showed was that fluid overload at dialysis initiation was associated with a twice as high a risk of mortality. And at the time we stopped dialysis, if there was fluid overload, so even dialysis didn't appear in this study to be correcting fluid overload so successfully. The risk of mortality had gone up from 2 to 2.5 times. When they looked at patients who received renal replacement therapy and who had fluid overload of more than 10% as compared to those with less than 10%, there was a 20% increase in mortality, which was highly significant. And when they looked at survivors and compared them with non survivors, what you see is that the fluid overload in both groups is actually worsening. So at the start of dialysis, the survivors had about a 9% fluid overload. And when they stopped dialysis, it had gone up to 13%. And in the non survivors, from 14%, it had gone up to 22%. So clearly, dialysis, of course, this is a post hoc analysis. Clearly, the renal replacement therapy here was not succeeding in reducing fluid overload in these patients. Now, when they looked at subgroups, if patients achieved a more than 10% negative balance with renal replacement therapy, seen by the brown bars here, the mortality was low at less than 20%. When you went to a patient who had a 0 to 10% positive balance, the mortality doubled and went up, or more than doubled, it went up to about 45%. And if the fluid overload was more than that, 11 to 20% or greater than 20%, the mortality was more than 55% in this analysis of the Picard study. They also looked at what happened to patients based on the percentage of renal replacement therapy days that the patients had fluid overload. And what they found was if there were no days on which the patient had fluid overload, the mortality was about 30%. And if all the days of renal replacement therapy were associated with fluid overload, so they weren't achieving a fluid removal that was significant, then the mortality doubled to around 60%. When they looked at what happened to fluid balance with CRRT and intermittent hemodialysis, what they found was that with intermittent hemodialysis, they started at around 11.5% fluid overload. And at the end of 10 days of renal replacement therapy, the fluid overload had actually increased to about 15%. Whereas with CRRT, they were able to achieve a negative balance. But interestingly, they didn't analyze what was the effect on outcomes like mortality, ICU stay, and ventilator days. So we looked at that in a prospective observational study between 2020 to 2023. We calculated fluid balance from ICU initiation to initiation of renal replacement therapy by looking at all the intakes, oral and intravenous, and all the outputs, urine output, Ray's tube losses, drains, abdominal or chest drains, and the ultrafiltration. And we summed up the daily fluid balances to give us a cumulative fluid balance and assess that on day 7 and day 30 of renal replacement therapy. Our outcomes were mortality at day 7 and day 30, ventilator dependency days, and ICU and hospital stay. We needed a target of 238 for our study to have an 80% power to detect a difference between those patients who achieved a negative balance versus those who did not. Eventually, we stopped the study at 232 patients. We had of whom 105, so about 46% survived. 63% of these had intermittent hemodialysis. This was an observational study, and 10% had CRRT. When we looked at the day 7 negative balance, a day 7 negative balance was associated with a 60% reduction in day 30 mortality, which was highly significant. And the cumulative fluid balance of survivors versus non-survivors, the survivors had about a liter of positive fluid balance, while non-survivors had 3 times that amount with no negative balance in that situation. We looked at also the effect of day 7 negative balance on ICU stay, and it was highly significant. It was associated with a shorter ICU stay and less number of ventilator days, both of which were statistically significant. And this paper is now been written up, and we are about to submit it for publication. So this is yet another study published in 2021 in which renal replacement therapy, it was all CRRT, was assessed in looking at what would happen to patients who had no fluid overload while on renal replacement therapy. And they compared the three groups: those who had a fluid overload that was less than 10% and a fluid overload which was more than 10% while on CRRT. The primary outcomes were in hospital mortality and 90-day mortality. And when they looked at the outcomes, what they found was that in the non-survivor group, 51% had fluid overload at the time of CRRT initiation versus 34% among the survivors. And the 90-day and in-hospital mortality of patients with fluid overload was dismal at 82% and 85%. So patients who had persistent fluid overload of more than 10%, almost all of them died, as opposed to about 50%, 57 and 59% in patients who did not have fluid overload of more than 10%. This was the multivariate analysis that they did. And when they grouped, the SOFA scores were significant, but when they grouped the patients into those with a SOFA score of less than 10 versus more than 10, either way, fluid overload of more than 10% conferred an almost 6 times higher risk of dying, irrespective of the SOFA score. So it was the single most important factor that determined whether a patient would survive or die, either in hospital mortality, or when they looked at 90-day mortality. The 90-day mortality, even with a lower SOFA score, was associated with a 10 times higher risk of dying if the patient had more than 10% of fluid overload. There was also something else in this study which they noted, and that was that a better blood pH conferred an 84% higher chance of survival. The odds ratio dropped down to 0.16 according to a blood pH which had normalized, as opposed to those patients in whom the acidosis wasn't corrected. We know, and this is an article from C. Jason of last year, that acidemia is associated with a lot of undesirable effects. It decreases myocardial contractility, it decreases the sensitivity to our noradrenaline and adrenaline infusions, it increases the work of breathing and causes respiratory muscle fatigue, it increases cerebral blood flow, but it is associated with a worsening obtundation, and it can produce hyperkalemia, hyperphosphatemia, increased protein catabolism, and many other things which we wouldn't want to have. So does correction of acidosis then improve any of these? This is a Japanese study which was published in 2019 of 34 septic shock patients with acute kidney injury who received intermittent hemodialysis within 48 hours of septic shock and AKI, and with blood flows and dialysate flows which were modest, and normal 4 to 6 hour sessions. These workers looked at the systolic blood pressure, the mean arterial pressure, and the measured minute volume, and biochemical parameters, including the pH, the bicarbonate, base excess, and lactate. And this is what they found, that the correction of the pH occurred, which was significant with the intermittent hemodialysis. The bicarbonate improved significantly, and this was associated with a better systolic and mean arterial pressures, a lower inotropic score, a lower norepinephrine dose, and interestingly, in this study, they said that lactate was significantly lower. Though if you look at the figures, a lactate of 6.9 and a lactate of 6.2 both look to be equally bad, and perhaps it was the number of sessions which resulted in this achieving a statistical significance. Flying in the face of this evidence is a Chinese study which was published in 2014. The normal tissue lactate clearance from liver and muscles is about a liter per minute, and the normal, as compared to that, CRRT lactate clearance is about 50 ml per minute. The normal lactate production in septic shock is about 3.35 millimoles per kg per hour, or for a 60 kilo adult, about 200 millimoles per hour. Now, in the Chinese study, they looked at 3 different CRRT doses: 20 ml per kg per hour, 35 ml per kg per hour, and 45 ml per kg per hour. And these were associated with filter lactate clearances of 32, 50, and 57 ml per minute, or a plasma lactate removal of 9 to 16 millimoles per hour in a patient who would be producing around 200 millimoles per hour. So clearly, CRRT in this study was highly ineffective in clearing lactate. And this is the myth that we sometimes think that we should start therapy do for metabolic acidosis. This is what the normal lactate is. if you have n moles of lactate produced, n moles of lactate are cleared by the liver and the muscles, and you would end up without CRRT with a lactate concentration of 1 millimole per liter. If you then added a CRRT of about 25 to 30 mils per kg per hour, your lactate would fall to 0.95. If the lactate production in septic shock increased 5 times and the lactate clearance remained the same, the lactate level would rise up to 5. And if you added a CRRT, it would drop to 4.8. If you had an AKI or a liver failure and the lactate production fell by 80% in the face of normal lactate production, again, without CRRT, the lactate level would be 5, and with CRRT, it would be 4. And if both the lactate production went up 5 times and the clearance decreased to 1/5, then the lactate level would go up to 25 without CRRT, and it would be 20 with CRRT. So how then does renal replacement therapy help lactate in any way? This is a nested cohort from 2 of the centers that participated in the renal study, Belomos renal study, and they looked at the pH, the plasma lactate, CO2, ionized calcium, etc., which they recorded 2 hourly for 24 hours in patients who were randomized either to the 25 ml per kg per hour versus 40 ml per kg per hour. And they also recorded the mean arterial pressure and the dose of norepinephrine every 2 hours in all these patients. And this is what they found. The high intensity CRRT improved the base excess very rapidly and persistently, while it took a much longer time to achieve the same effect with the 25 mils per kg per hour of CRRT, CVVHDF in this patient. Although in the end result, about 50% of the patients in each of these groups had a normal base excess by 24 hours. When they looked at the mean arterial pressure, the high dose CRRT, but not the low dose CRRT, significantly improved the mean arterial pressure by about 7 millimeters of mercury from the start, while it was virtually the same in the group which received low dose CRRT. And when they looked at the norepinephrine dosage, high dose CRRT was associated with an improvement or a lowering of the norepinephrine dosage, perhaps because the mean arterial pressure was improving, which was not the same in the low dose CRRT. So what they found in this study was that while they were improving the pH and the bicarbonates, they were also achieving better mean arterial pressures and lower norepinephrine doses with high dose CRRT as seen here, but not a significant change with the low dose CRRT. So 40 ml per kg per hour was improving mean arterial pressure and lowering the requirement for norepinephrine, which may be associated with a better tissue perfusion. So the tissues would clear lactate better, and that's what they found. That with the low dose CRRT, the lactate did not significantly change, but it changed with the high dose CRRT, which may have been achieved through better tissue perfusion with better mean arterial pressures and lower norepinephrine doses. So we are left today with a situation in which we've got to remove fluid, and we've got to do so without producing tissue ischemia, which worsens our lactic acidosis. And this was studied in a study by Silversides, which was published in Critical Care in 2014. Silversides looked at 2 things: a cumulative fluid balance of total fluid balance. He looked at fluid overload, which he defined by 10% of an increase of 10% from the admission weight. And he looked at intradialytic hypotension, which he defined as a mean arterial pressure of less than 65 or a reduction of 20% from the start. And he found that intradialytic hypotension occurred in almost 87% of all the patients at some point of time. And this is what they found. A fluid overload of 10%, more than 10% versus less than 10% was associated with a twice as high risk of mortality at 90 days. And intradialytic hypertension, just a 10% drop in blood pressure, was associated with a 14% higher risk of dying. So what they have to do, so the challenge before workers today would be to remove fluid safely without producing hypotension. Because on one hand, the patients would die of pulmonary edema or fluid overload, and on the other hand, the mortality would be increased by worsening tissue perfusion with every hypotensive episode. So an analysis and in fact a systematic review was published by Adriana Dovres and others in 2019 in Critical Care, I think. And it looked at various methods which have been used to improve hemodynamic tolerance in patients undergoing SLED by cooling the dialysate, using sodium profiling, increasing the ionic calcium by a higher calcium dialysate, reducing the dialysate flow, but most of all, a conservative level of ultrafiltration. And the attempt to quantitate this first came from Raghavan Murugan and John Kellum at the University of Pittsburgh, where they looked at patients who had received any form of renal replacement therapy and calculated the net intensity of ultrafiltration. The net intensity of ultrafiltration they define as the total ultrafiltration done in volume in ml per day divided by the hospital admission weight into the duration of renal replacement therapy. And when they looked, and when their primary outcome was 1 year mortality, they stratified patients whose intensity of ultrafiltration was 3 groups. 20 ml per kg per day was low intensity, 20 to 25 moderate intensity, and more than 25 ml per kg per day was high intensity. And this is what they found. When they compared the 3 groups, the hospital length of stay and hospital mortality and 1 year mortality were all lower in the patients who received the high intensity of ultrafiltration, that is more than 25 ml per kg per day, as compared to the low intensity of less than 20 ml per kg per day. When they did a complete adjusted analysis, a high intensity versus low intensity was associated with an almost 40% reduction in the risk of mortality at 1 year, and moderate versus low intensity, there was no real difference. So from this study, it appeared that a minimum of 20 ml, 25 ml per kg per day of ultrafiltration would reduce the 1 year mortality, which for a 60 kilo adult translates into a negative balance, because they're talking about net ultrafiltration, a negative balance of around 1.5 to 2 kgs of ultrafiltration per day. So another study which was done by Kashani's group at the Mayo Clinic, another single center study, set the cutoff of 35 ml per kg per day, and they put patients as low as less than 20 ml, like with the Pittsburgh study, moderate 20 to 25 to 35, and high intensity more than 35. And they looked at 30-day mortality, and this is what they found, that a 35 ml per kg per day was associated with a 38% reduction in the risk of mortality. The other significant things were a SOFA score and early hypotension. So once again, every episode of early hypotension during ultrafiltration was associated with a 32% higher chance, or 0.32 times risk of increased mortality at 30 days. When they looked at the fluid overload and 30-day mortality, 35 versus 20 was associated with a 40% lower risk of mortality, 35 versus less than 20, a 60% improvement, and 20 to 34 versus less than 20, a 32%. So anytime you increase the net ultrafiltration per day in patients who had a fluid overload of less than 5%, it was associated with a reduction in mortality. When they looked at the excluding the patients who had less than 5% fluid overload, once again, there was a significant improvement. If the the net UF was more than 35 ml per kg per day, it was associated with a 50% reduction in the risk of death at 30 days. So both these studies suggested, though with different thresholds, that if you could do 25 to 35 ml per kg per day of net negative balance, then the mortality at 30 days and extending all the way to 1 year would improve. But with the caveat that if you achieve this at the cost of hypotension, then you were once again increasing the mortality. So it appeared that one would have to do the ultrafiltration at a rate which did not produce hypotension and at the same time achieve the target. And once again, Murugan looked at this by analyzing a post hoc analysis of the renal study, in which he stratified patients into 3 groups: those who received a low rate of ultrafiltration, less than 1 ml per kg per hour, which would translate to about 24 ml per kg per day; middle 1.01 to 1.75 ml per kg per hour, which would be about 24 to 42 ml per kg per day, and high, which was more than 1.75 ml per kg per hour or more than 42 ml per kg per day. In his primary outcome was 90 days survival, which was what the renal study looked at. He stratified patients into three groups for their mortality at 7 to 12 days, 13 to 25 days, and 27 to 90 days. And he found that 1.75 ml per kg per day was always associated with a higher mortality risk at every level as compared to less than 1 ml per kg per hour. And when it was not significantly different for the group was 1.01 to 1.75 versus less than 1. And for every net ultrafiltration rate of 0.5 ml per kg per hour increase, the mortality would be increased by 8 to 13%. So what this study showed, and importantly, he was once again looking at net ultrafiltration. So this is not the ultrafiltration set on the machine, but it included the net negative balance per hour, taking into account the ultrafiltration achieved by the CRRT, along with the intake of fluids being given in the form of drugs, blood products, and nutrition, and various other fluids. And Murugan came up, therefore, with the fact that ultrafiltration rate is associated with a J-shaped curve. If you do too little ultrafiltration, less than 1 ml per kg per hour, then the patients would die from organ edema. If you did more than 1.75 ml per kg per hour, then what you would have is ischemia, organ ischemia induced by hypotension, and once again, the mortality would increase. So the golden mean seems to be, or the safe zone seems to be, an ultrafiltration rate of between 1 to 1.75 ml per kg per hour in CRRT, when this translates into about 24 to 42 ml per kg per day, which is in essence reflecting what both the Pittsburgh and the Mayo Clinic studies told us in terms of net daily ultrafiltration. Now, this is true of CRRT, which is a continuous therapy. We need to worry about what would happen in patients receiving intermittent or hemodialysis or SLED, which is not continuous therapies, and how much would we need to increase the ultrafiltration rate to achieve the net daily ultrafiltration target of between 25 to 35 ml per kg per day, which the earlier two retrospective studies suggested was good. So what we did was to do a study in which we randomized patients undergoing SLED into, this is the RELIEVE study, and the RELIEVE study is going to settle the question for CRRT because the studies done up till now are negative, retrospective studies. This is a prospective randomized control study which will randomize patients into net UF rates of between 2 to 5 ml per kg per hour versus 0.5 to 1.5 ml per kg per hour. Importantly, the primary outcome is to see whether these groups will separate by a minimum of 0.5 ml per kg per hour in terms of delivered ultrafiltration net rates. And the secondary outcomes will include ICU length of stay, hospital mortality, ventilator-free days, and many other important outcomes. Now, we did a study in which we randomized 67 patients undergoing SLED. As I said, SLED is done for part of the time to 4 ml per kg per hour versus 2 ml per kg per hour versus a control group in which it was prescribed by the treating clinicians. And this is what we assumed, that our primary outcome was hypotensive episodes and a decrease in the vasopressor dependency index in these three groups, because this was too small a study to look at mortality. What we found was that there was the hypotension, much to our surprise. The minimum number of hypotensive episodes occurred in the group undergoing ultrafiltration at 4 ml per kg per hour, and it was maximum in the control group, which got ultrafiltration at around 2.65 ml per kg per hour, and it was intermittent in the group which got 2 ml per kg per hour. When we compared the individual groups among themselves, the session durations, of course, were longer in the patients who got 2 ml per kg per hour, but it was not surprisingly double that of patients who got 4 ml per kg per hour. The median value here was 11 as compared to 8 hours. So it appeared that most sessions got prematurely stopped in the group which were randomized to 2 ml per kg per hour. And that's exactly what we found. It was 9 by 54 versus 6 over 49 sessions when we did an individual comparison. The hourly ultrafiltration was naturally higher in the group which got 4 ml per kg per hour. The average value, the median value was about 250, and it was 125 in the group which got 2 ml per kg per hour. Now, if we look at what this 2 ml per kg per hour achieved, with a median time of 11 hours and a median ultrafiltration of 2 ml and an ultrafiltration of 2 ml per kg per hour, that translates into 22 ml per kg per day, which is as in falling into the group which had a poorer outcome. And the group which got 4 ml per kg per hour, we were not aware of Murugan's studies when we planned this study, got a median duration of 8 hours and an ultrafiltration rate of 4 ml per kg per hour. They would get 32 ml per kg per day, which was within the targets suggested by the Pittsburgh study. When we looked at multivariate regression analysis, hypotension produced a 75% increase in the odds ratio for mortality at 30 days, and it was also associated with an increase in the ICU stay and ventilator days, as was the initial vasopressor dependency index. So, if I had to summarize what are my newer targets, I need to define the primary goal daily for my renal replacement therapy. Would it be fluid overload, fluid control? Would it be acid-base control or small solute control? And then, as my own study in SLED showed me, I didn't achieve my prescribed target in the SLED patients because there were more premature terminations in the group which got 2 ml per kg per hour. So I needed to maximize my delivered to prescribed ratio, which has also been shown for CRRT in various other studies. We need to do no harm. The hemodynamic instability, of which hypotension is an essential part, is associated with a higher in-hospital mortality and decreased renal recovery. So we need to avoid the complications. So that would be my second target: avoid the complications and minimize therapy errors. And of course, review the appropriateness of medication dosing when we do renal replacement therapy. That's a topic in itself which I haven't dwelled on today for lack of time. And of course, there are need to be the targets. There are still many unanswered questions for which research is required. And so I'd end with two quotations which I learned from two good friends of mine. In fittingly, one of them is an intensivist and the other a nephrologist. As long as we keep searching, the answers will come. That was said by singer Joan Baez. And in 1858, Thomas Huxley said, "The great tragedy of science is that a beautiful hypothesis is often slain by an ugly fact." Thank you.
So thank you, sir, for this very nice and I think thought-provoking discussion on newer targets. Now the session is open for the panel discussion by our esteemed panelist.
So thank you, Lobo. As usual, for a lucid talk, and you make us think. So for the larger audience and my colleagues on the panel, many of you know Dr. Lobo has done some original work, and he showed a small part of it in his presentation. In Hyderabad, in Pune, all of us after 2000, we are comfortable offering a patient what the patient needs. So one of the questions that will come up is, which is a better modality? And he did show a patient who had a long session of a intermittent or SLED versus CRRT. So most of our ICUs in India now believe that a given patient, you should have the wherewithal and the capability to offer IHD, SLED, HDF, and CRRT. And when a patient improves hemodynamically or clinically, you can transition from one type of modality to another type of modality. I would like to open the discussion with this saying, so all modalities are good in a particular given situation. You should know what you are offering, and your team should be good at doing that particular protocol. Thank you.
Yeah, very good talk, Dr. Valentine. I think beautiful comments from Dr. Rajshekhar. So quite an exhaustive amount of evidence was put in. So one thing from our intensive care perspective, I need to make a comment is, this whole concept of cumulative fluid balance has been very rigorously tested in intensive care, and it's proven beyond doubt all the perils of having cumulative fluid balance. And same thing was reflected from your narrative in patients who are undergoing dialysis, that fluid overload seems to be a very important detrimental marker for the outcome. So this has been very clearly established. And in fact, the silver slide study that you mentioned, Dr. Valentin, so that was the largest meta-analysis with regards to cumulative fluid balance, and it included all the cohort of our patient sepsis, ARDS, so on and so forth, where it was shown to have a worse outcome. And even the subgroup analysis of the VAST study, which was a big sepsis study. This is, I'm talking about in sepsis patients who developed kidney injury and who undergo dialysis. The subgroup data from the SOAP study clearly showed that how early RRT to mitigate this cumulative fluid overload improved outcomes. I'm talking about acute care of severely septic, unwell patients who needed dialysis, where cumulative fluid balance was mitigated by RRT in 3 days if needs be, showed good outcomes. So this fact has been well established in our acute care that cumulative fluid balance for whatever reason is bad, either they go on dialysis or off dialysis. Having said all this, just a reflection about all the beautiful trials that was quoted in kidney injury like START AKI and Akiki 2 trial, which is the latest 2021. So the concerns still remain, because what did Akiki 2 trial show? Akiki 2 trial in 2021 said either you do early RRT or late RRT. Your RRT 3 days, there was no difference.
No difference.
But early RRT showed lesser mortality as compared to the late RRT. So is this a reflection? Because the delayed RRT there, the criteria was patient should have had a fluid overload. So how ethically was this sound, given the data that you showed that in kidney injury patients, the fluid overload is a bad reflection. But here in this study, which is as latest as 2021, they waited for these patients to have a pulmonary edema, and they showed there was increased risk of death. So these are some of the limitations of this big trial. Although the evidence was very much there that it increases mortality, but they had this patient group randomized between these two groups and showed worse outcome or worse mortality with delayed RRT, where one of the criteria was fluid overload or blood urea nitrogen more than 140 or hyperkalemia. So these are all some of the things that come to our mind. Just to end my little comment, so fluid stewardship has become terribly important for us. In fact, one of my LB training is doing a study on cumulative fluid balance as a determinant of outcome in de-resuscitation, because now there are 4 Ds in our fluid resuscitation. The last D, one is the dose, the type of fluid, the duration, and de-resuscitation. So pretty much that was reflected. So I'll just stop my comments with one last one. The lactate one was very enlightening to me, because we initiate dialysis in ICU because of high lactate and severe acidosis to circumvent. But what was enlightening from your talk was that seldom do we correct the lactate, but we do as a desperate measure because we would be losing hemodynamic stability. But your slide, the beautiful slide you showed us, that your lactate clearance is very, very minimal despite CRRT or hemodialysis. So I stop my comments. So I know I've told a lot, but we can reflect upon it with others' comments. Thanks, Valentin, for beautiful talk.
Yeah, I will not make that long comment because I don't think that we have enough time to do long comments, but I really enjoyed your presentation. It has a lots of very good information. And I was always troubled by the term early and late because of an intensivist. I don't know what is late. Late means bad under any circumstances. So I don't have something called early and late dialysis. There is something called indicated or not indicated. If it is indicated, I'll do it now. There is nothing called late. So the late is always bad, no matter what we do. So early when the indication is there. So this is in order not to trouble myself as an intensivist. My mind is always do things on time. If it is indicated, do it. There is nothing called late. I only want to ask you, Lobo, about something which is that you mentioned several times when you are talking about the volume overload and you make it interchangeably with pulmonary edema, I usually have a problem with that. Volume overload doesn't equal pulmonary edema. Pulmonary edema is a state of anhydrostatic fluid accumulation in the lung because of the imbalance between the filtering and absorbing force at the pulmonary capillary. And that will be compounded more if the patient is having a lung injury. So using those two terms together is usually not very good. Neither the 10% increase in the total body weight from the time of admission till the time you start, nor the measures which we use to the pulmonary edema are equal. So I'd like to hear from you. I really need to have those as separate entities. Pulmonary edema is not a volume overload, and volume overload is not a pulmonary edema. And they should be used separately when we talk about fluid removal from those. So I have people in pulmonary edema who are volume depleted, and we see that all the time from cardiology patients. The patients are excessively on diuresis, and they are volume depleted, intravascularly depleted, and yet because of their left atrial pressure, left ventricular dysfunction, high pulmonary venous pressure, they are in pulmonary edema. So if you agree with me, just explain it to our colleagues who are listening that the volume overload is not pulmonary.
I agree with you fully that I hope I did not give the impression that the two are interchangeable. If so, that was not my intention. So I agree fully with you that yes, there can be patients with acute lung injury with leak where there is a leak of fluid, and they could be volume depleted in such a situation. Agree fully. I should have said organ edema and specified that I'm talking about capsulated organs, which is where fluid overload almost invariably results in organ edema. I agree also with the point you made that not every patient with pulmonary edema is going to do well with ultrafiltration. If that is because of a lung injury, then those patients could actually worsen if one tried to remove fluid. And that is perhaps one of the problems that I don't think any of us has an answer to. And that's the group of patients who do worse. These patients, fluid is being poured in and it's leaking out of the intravascular. And even Edrina Duvas's review says that, the 2020 or 2021 review, I think it is, said that you can't improve these patients by ultrafiltering them. And if you do, you could be doing harm. So it may we don't have an answer yet whether that reflects that this is simply the most severely ill patients in whom ultrafiltration is going to do harm, or whether we need a better method of doing it. But yes, the point is very well taken that you made, that pulmonary edema and fluid overload are not interchangeable, but a more than 10% fluid overload calculated by the way which has been done in the studies is associated. And Dr. Angap also made that very important point that an elective start to renal replacement therapy to prevent fluid overload, perhaps that's the sort of trial we need to be doing, randomize patients into those two groups and show that it clearly makes a difference. And today we also have a very useful tool in the form of POCUS. So all the studies that have been published and the ones that we did also, we just looked at chart balances. But today there is a tool to look at the IVC diameters, the lung lines, the vexes. There are many tools to tell us whether we are dealing with fluid overload, lung injury, etc. And I hope that the future will see better studies in that. Thank you.
The one you commented about the patient developing hypotension, and you related that to the amount of ultrafiltrate we are doing. If this will happen during your dialysis, you advise your colleague to either reduce or you augment your hemodynamic support.
Yeah, so it's a very difficult decision, and I think I would be happy if in this patient whom I have to deal with, who is on a full dose of noradrenaline, a full dose of adrenaline and vasopressin, and has fluid overload, so I need to take out, but the moment I start, the blood pressure starts to go down. I'd be happy if this patient also has acidosis, low calcium and high potassium, because then there is something I can correct and hope that the circulation will improve when I correct the pH, when I correct the potassium, when I correct the calcium with my renal replacement therapy. I get a better circulation. I can actually bring down the pressures in such a situation and hope that tissue perfusion will increase. Otherwise, I'd be doing the vicious circle in the way that I don't want to do it. I'm causing hypotension, increasing my pressures, worsening tissue perfusion, increasing the lactate. Again, the pH drops down because of the increased lactate. So yeah, I need to do both. And I don't think I have an answer for every single patient. And as I said, even the studies tell us that perhaps there are some patients who are just so ill that their circulations are just so bad that we can't ultrafilter them no matter what the situation.
And what you will tell to your colleagues who are still insisting on using what looks like the diuretic challenges in order to delay the renal replacement
Yeah.
therapy?
So what I would do is I would do a furosemide stress test once, 1 milligram per kilogram, and that's been shown. 1 milligram per kilogram, and then the rule of 200 ml of urine at 2 hours will predict whether this patient is going to need renal replacement therapy down the line or not. If I don't get that 200 ml, I won't be trying Lasix infusions, subsequent doses. I would just wait and do renal replacement therapy.
And that will answer the question of early versus late, as I just mentioned.
Yes. I think yeah, there have been analysis, and I didn't go into that. There was an analysis, and I think Tapas, didn't we discuss it in one of the webinars last year? The 2023 September article, which was a post hoc analysis of ideal ICU, where they said the patients who started early versus late on creatinine criteria, the early group did badly. But if you started early versus late based on fluid overload, they did better with early.
Just another point, Valentin. So we have clearly understood the one of the study that you showed where 2 ml versus 4 ml clearance, 4 ml had a better hemodynamic stability. And that has been shown again in our intensive care that hemodynamic stability can worsen with a volume over resuscitation. So it is becoming increasingly recognized that we have to be restrictive with over resuscitating, because over resuscitation has caused hemodynamic collapse or cardiovascular collapse, and because of all the fluid sequestration that happens in organs. So that has been shown from the Peace study and few other studies.
Thanks. Yeah.
Thank you for this lucid discussion. Dr. Lobo, one query which is coming in my mind, because I had also the similar presentation in the discussion by the Turkish Society of Intensive Care few days back. So do you think like sequential approach of first you will be doing the ultrafiltration without removing the solutes, and then combined dialysis and ultrafiltration in the selected patients, that would be improving the
Yes, in selected patients, that option is certainly there. Most machines have that option of isolated UF. The theory behind that is that when you remove only water, you increase the plasma osmolality. And so when you increase the osmolality, you increase the filling of the vascular tree from the interstitium and the intracellular fluid. Now, how well this works in the patient whom Dr. Ashraf was talking about, who is on high pressures, who has got leaky capillaries, where everything that you try to pour in is leaking out, I'm not really sure. So while this works beautifully in chronic kidney disease patients, sequential, and it works in a small group of acute patients, the very sick patients, I don't know. And I am not aware of a study which has looked at sequential in that group of really sick patients.
Agree, completely agree. So maybe we can end with that. The time is here only to have a perfectly designed RCT on the optimal ultrafiltrate net and the mortality. So what do you think, Dr. Rajsekhar, as well as Dr. Lobo and Dr. Rangappa, Dr. Ashraf? So because till now there is not a, like I searched also like a lot of literature, but I didn't get any good article which suggests that the RCT is supporting certain form of ultrafiltrate net.
So I think everybody has talked, Dr. Lobo, Dr. Ashraf, and Dr. Pradeep, that fluid overload is bad. Having said that, we also need to know where the fluid is. Dr. Ashraf clearly talked about an intravascular volume depleted state. In that patient, if you are removing volume, you are going to get more of organ ischemia, which is proved again in RCTs. My simple submission to everybody at Tapas has been doing such a great job from Indian subcontinent. We should first have a epidemiology of AKI across all our ICUs. It's high time we did that. We tried doing something like a registry some time ago and we were not successful. This platform with all of you as stakeholders, I'm aware Dr. Kashani from Mayo, they are doing their AKI EPI2, that study, and they aim to enroll 10,000 patients. It will be mainly to look at the epidemiology. And even if we get 10 centers from the country involved, we know at least how our AKI behaves. I always strongly felt we are very different from the Western, but we always use the Western data. And I can give you several examples and we don't have time for that. My request is we get into this AKI EPI2 study, look at our own across the cross section of ICUs, how our AKI behaves, and we start having our own RCTs and our own data. And I can assure you, whenever we looked at whether it was a peritoneal equilibration test in Indians or the acute kidney injury biopsies that we did, even in the ICUs, we are very, very different patient cohort. Maybe principles wise, we are the same, but the way we take fluid, the way we handle fluid, the drugs, everything, we are very different. So my request with Tapas being here and all of you on board, please look at epidemiology of our patients in this.
Sure. Thank you, sir. So we would be definitely taking this forward. Yeah. So with this, Sanant and Dr. Jacob, anything from your side before we end up this fantastic 1 hour or so discussion on your targets?
No, Tapas, I think the questions that I had is already answered. So it was nice to see that the questions that I had earlier was phase-wise addressed by the panelists. So I don't have anything else to ask or add here. Thank you.
So Dr. Jacob, anything?
Nothing, Dr. Tabas. I am same here.
Yeah, perfect. So thank you all the panelists and the speaker, and we had really good discussion at the end. So now it is time to have the trainees section, that is the quiz. So what we will be doing, we will be sharing one Google form in the chat box, and we request the trainees attendees to attempt these questions. So there are 12 questions and there would be 10 minutes. So you can attempt these questions and we will get the answers immediately, and we will get that who is in the top 3 or 5, and then we would be showing you the answers. And with me, Dr. Srivastava Nagachandan from Kochi, Kottayam, and he would be conducting the quiz for the discussion part and also showing you the answers. So welcome, Dr. Srivastava. Are you here?
Yes, sir. Thank you, sir. Thank you, Professor. I'm here, sir. I think
So
we'll begin the quiz, I think.
yeah, so I have shared in the chat box only. You can all get the questions through that Google form. So I request all to start the questions. So we will be having 10 minutes break here. And in the meantime, if any attendee is having any question or any query, they can post in the chat box and we will be happy to take those questions.